has 4 causes. And if you'll just break this down with me and just be like totally good. Now listen, the whole Gait talk is just to get you academically prepared for what it is that you have to be doing. And when you look at Gait, the very first thing that will cause abnormal gait is pain. Now you've heard this term before, and that is antalgic gait. So, what I'm going to do is I'm going to go from there. Well, let me do this. Number 2 is weakness. Muscle weakness. Also, you will see this portrayed in paralysis. Now, I'm going to be very careful with this because I realize that you're in neuro right now. You're going to talk spinal cord injuries next semester. So I just want you to kind of think, when you hear the word weakness, sometimes they will synonymously attach the word paralysis to that. I don't mean at the licensure level. I mean just in clinical practice, you'll hear them say they have some paralysis of this muscle. Just use that and say they have weakness. Unless there is complete paralysis. Now that's where things kind of start getting nasty. And I bet you've seen this word complete and incomplete, right? As they attach to spinal cord injuries. This hub day will work with that and really help to flesh that out. And I will also help with that in seminar. But you're going to catch these words a lot. And so you just kind of have to like really quickly in your brain go, oh, they're just talking about weakness. Range of motion limitations, which we covered extensively when we talked about range of motion. That's muscles are tight or there's a joint restriction. And that comes about most commonly when there is contraction. And then I would probably push you back to the idea of, what were the 4 types of contraction? I know that was kind of a nasty little thing for you, but just kind of think, what could cause gait abnormalities from the muscle being tight? Now listen, that's different from number 2 being weak. If the muscle's tight, that's different, right? Think about this from the standpoint of when a person stands and they stand up and they're as straight as they can get, and this muscle right here is tight. Or their head is forward and you say, look up, and they can't because these muscles are tight. There's a contracture there. And then the last thing is neurological involvement. Now, you look at that one and you go, wait a second, when you just said paralysis up there, isn't that neuro? Yes and no. They've broken this down into 2 things. That muscle could be have a paralysis set forth by something other than a neurological condition, right? So you just kind of have to understand that when we look at these, we're going to lump these abnormal gait patterns together, but these are the 4 causes right here. So let me just jump into the first one, and that's pain. Pain changes things, especially about how we move and about how we're willing to move. So most commonly, pain is associated with lower limb injury, right? A sprained ankle, a torn ACL. You just pull the calf muscle. Also, there can be pain from the trunk. Now, you're all very young. I don't know if any of you have ever had back problems before, but when you do, it changes the way you move. A lot of times it changes how much pelvic rotation there is. And we'll look at that this afternoon. I don't get too far into the pelvic rotation side of things yet. We'll jump into that on the next talk. But the pelvis needs to rotate. And we should see that. Sometimes people walk with back pain and they lose pelvic rotation and they do this right here. And they fall kind of into a flexion. And I'm going to be careful because I know you've heard the word flexion synergy. I'm not saying flexion synergy, I'm saying flexion bias. They like to be in flexion. They lose pelvic rotation. You see that? They don't have a lot of pelvic rotation. Or they like to be in extension. And so they, again, lose pelvic rotation. We'll talk more pelvic rotation in a second. Another thing, surgery can definitely cause us to have pain. But it's not just in the lower limbs. Has anyone had their appendix out? How was it?
It was terrible.
It is terrible. That's because we're men. Any one of these women in here can have it done and they'd be up and running.
24 hours.
Me and you were just like, oh, this is bad. My wife had her pelvis like lacerated open 4 times, and she's like, I'm walking. I had 3 holes. One here, one here, one here. And this thing that's about the size of my thumb taken out. She had a human jerk out of her body, and she's up walking that night. They wouldn't let me walk for 3 days. They said, it's because you're a man. Sit down. Just stay there. You're not ready for this. Pain changes things. Also, it says up here that there's visceral pain. And I just put this word in there to kind of help you understand that if a person is ill, if they've had a stomach virus, right? And this is kind of, listen, I got to tell you, there's one component of these masks that I love, that I may not get a stomach virus, and I'm washing my hands like crazy. Like, I'm holding out hope that I won't get a stomach virus this year. Although it is a great way to lose weight. Does that tell you about my disordered eating?
I don't know about that.
But you're like, oh man, I feel bad. But that changes your gait, right? So think about these people that you're working with. Those things change their gait. So when you have injury or illness, expect some changes. Maybe that's a temporary thing, right? And that's going to resolve. The next thing that we want to look at is this bullet that says, if it's a true antalgic gait, they will have a shortened stance time. Now, stance was the longest part of the gait cycle. At what percentage? 60%. Did everybody hear that? 60% of your gait cycle is in stance. Except when there's an antalgic gait. And then it looks like this. Right leg's injured. I don't care. You can put in ankle sprain to ingrown toenail. And what happens? We accelerate through stance phase because we don't like what? Weight bearing. That's what's painful. Weight bearing is painful. So it accelerates. You've got to be good with that. Also, they can exhibit a touchdown appearance. Now you got to go back to intro to PT, right? What's touchdown? Yeah. That's touchdown appearance. But look, see how much faster it is? And you can see how I'm accelerating the contralateral side. But they may have a touchdown. May. Does that mean they have a drop foot? Or a plantar flexor contracture? Maybe not. See, what we're doing here is we're setting the tone to say, this one right here is probably temporary. So as far as abnormal gait patterns are concerned, this one may go away when the primary problem goes away. The next one here is a little different. These are weakness patterns, and I'm going to show you videos of these because I cannot emulate these as well as the videos will show you. But there's a golden rule to muscle weakness. So write this down, highlight it, and tell your friends later. Muscle weakness gait patterns always move the weight over the weak muscle. They always move the weight over the weak muscle. Another word for that is they always move their center of mass over the weak muscle. So let's take a look. Yes, I'll explain that right here.
Can you repeat that just one more time, make sure I got the phrase that you said?
The person will always distribute the weight over the weak muscle. All right, so take a look up here. This is a glute max gait. So on your slide there, the first one is the glute max gait. All right, so take a look at this person, watch what they do, and then while you're watching, chew up, they're moving their weight over the weak muscle. Let me say it again, they're moving their weight over the weak muscle. Oh, thank you, Ryan. These are all quick. Look at where the weight is. This is a glute max gait. Now, some of you are looking at that and you're thinking, that guy's walking with just a big old lumbar lordosis.
So that would mean that he had a weak left glute.
I'd say bilateral weak glutes. But look at where he's doing his weight, or positioning his weight. He redistributes it over the weak muscle. Why? Because if we take our center of mass, we load. Sorry, Google hijacked it. We load over the weak muscle, and we stabilize it by doing so. And a great example is this right here. And you've seen this one before. You know this one well. In fact, I taught you this in your first semester. This is the Trendelenburg gait. Before we watch the Trendelenburg gait, can you tell me what muscle is weak? The glute med. Now, I know that Ms. Hobday had a conversation with you the other day. So let's just look at this from this standpoint right here. And this is a posterior look, all right? If we have the sacrum into the coccyx, and we have the femur, and then right here would be the glute med, right? Everybody good with that? If this muscle is strong during the stance phase, the pelvis stays somewhat level with some tilting allowed, or I should say, lateral pelvic tilt allowed just to accommodate what? The swing phase of the contralateral leg. Now watch what this lady does. And it's subtle. It's subtle. You see it? Bam. It's ironic because she's got her cane on the wrong side. Watch again. She drops. What side is drops?
Right side.
The right side's dropping. So what side's weak? The left side's weak. So what does she have, a left or a right Trendelenburg? A left. Now, to help prove my point, here's what she does. This side drops right here, right? So what she does is she's shifting her weight over the weak muscle. Now you really got to think about this. Some of you are like, no, wait, this side drops. That means they're shifting their weight here. No, 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 no. If this is moving this way, what she does is she shifts her weight over the limb here, the weak muscle. Same with a glute max gait. This is also known as a glute med gait or a Trendelenburg gait. Both are synonymous. Yes, sir.
So she's dropping on the right side, and you said that her left one was weak?
Yes.
But then when she drop it, she put it, never mind, makes sense, there you go.
It takes a minute. Listen, don't feel bad about that.
It took a minute.
It takes a minute. It does. Good for you for working that out in your brain.
And you would name that a left?
That would be a left Trendelenburg or a left glute med gait.
Oh, okay.
You may see them named either way.
But it's named for the weak muscle.
It is named for the weak muscle. Yes. It is named for the weak muscle. And I want to tell you this too. A lot of times you're going to see bilateral Trendelenburgs. But in the instance, like, let's just say it this way. If they have osteoarthritis in their knee, in their right knee, a lot of times that side will get weak because they don't spend a lot of time weight bearing in it. And so that's where you'll start to see that when they go into stance phase there, they'll kick out and get that lateral pelvic drop on the opposite side. It is always named for the weak muscle. So in this instance, it's a left Trendelenburg or glute med gait.
I wonder why they let her have the cane on the wrong side then.
Well, they do it intentionally, so
Can't tell you. Can't tell you. But you know, Scott, honestly, what I see a lot of times is general practitioners, they don't always meet that need. They don't accommodate and say a patient should do this. I mean, how many times do you see people leave the ER with crutches that don't fit? I mean, that's just a common, like, you just run them out. And all of a sudden they're like, hang on, I'm on crutches. Right? They don't fit. Why didn't they fit those crutches? Why didn't they fit the cane? If they can't fit a cane, they won't know what side a cane goes to. I mean, that's just not their job, I guess. At least, maybe they don't feel like it. I don't know how to answer that question politically correct. I got the same problem. But look at it, again. Oh. That is a left Trendelenburg. Oh, my weak quads is out. Alright, so let's just kind of pretend. Who would like to see if they can demonstrate a quadriceps gait? We don't have a video. I need one of you bright young pupils to help out your peers here. What do you think a quadriceps gait would look like? Now go by the rule. The weak side gets the weight. This is what they do with a glute max, right? Here's what they do with a glute med. If they're kicking their weight over, trying to accommodate. I'm not very good at it. Bill's pretty good at it. What do they do with a weak quad? Now, by the way, lots of people have weak quads, right? That's why we discuss it in balance and talk about how they should straight leg lift or stoop lift safely because they have weak quads, because they can't accommodate that movement right there. What do you think a weak quad gait looks like?
They have hyperextension.
Why don't you show us?
I just saw something in Miss Holiday's class, but I can't.
Okay.
So it would be, I guess it would be like that.
Yeah. Yeah.
So it pop back.
Exactly. Exactly. Do you see it? Their quads are weak, and this is where this word recurve bottom comes from. recurve bottom, they are backlocking those knees. Why? Because they don't have muscle tone in the front to stabilize. So the only way they can stabilize is to backlock. And guess what their weight does? It moves over the weak muscle. Right here. So again, here's glute max gait. Here's a weak quad gait. And they backlock those knees. Are you getting that term, backlock? Alright. Let me just see real quick here if I've got a different. This isn't a good one. This is some poor student who's being made to do it. See how their weight is staying over the weak muscle? And maybe that is a decent, or a real case, I don't know. I'd say it's not, and then it turns out that they are. But definitely backlocking that knee, that's the key indicator there. Hamstrings gait, that one's going to look a whole lot like our glute gait. Let's see if we can find a quick video on that. I never could find one, I don't think, before, so. That one's not well described. How about these though? The ankle dorsiflexors have come up today. We talked about a concentric component and an eccentric component. Let's just do it this way right here. This young lady has a concentric weakness. Let's see if you can. Oh, what happened? The video is terrible, I'm sorry. You see it? Watch it again. No heel strike there, huh? Traditional terminology's out the window. Gonna have to bring in Rachel's los amigos. One more time. Now that's a concentric muscle weakness. What I described earlier too, by the way, this is called a high steppage gait. They have to pull their leg way high in the swing phase. In fact, their swing phase looks a lot different with an exaggerated hip flexion, which is generally pretty strong. Right there. Now there's another one that's not concentric about the dorsiflexors, it's eccentric. And when they go into heel strike, they have a foot slap. So you have high steppage gait, which is concentric. You have foot slap, which is eccentric. And I do give you a test question on that.
What was the one that was concentric.
High steppage gait. High steppage gait.
And that one's described as no heel strike.
The foot slap is eccentric. It does have a heel strike. However, it has no eccentric control. And so you get that, which is foot slap, right? The steppage gait, they don't have concentric control, so they have to lift up their leg higher, which I'm exaggerating. Sometimes though, this is also referred to as equinus. Equinus means horses, and this comes from how horses, they can train them to do kind of a high knee, well I can say, because they're not the knee, it's a hock. But they will teach them to do this fancy little step move. That's known as a equinus gait or a steppage gait.
So you can have a weakness of concentric but not eccentric?
Yep. Yeah, you can.
And the foot slap is no eccentric control.
Foot slap is eccentric loss. Steppage is concentric loss.
And equinus and steppage are like same thing?
Yes. And then just to kind of tie this in, the triceps surae. Has Bill described what that was?
I don't think so.
When you think of triceps, most commonly you think of the muscle that's on the posterior aspect of the humerus, right? In this specific, and I want to catch this back up, this is a great little video about the triceps surae. There's a few things that I would highly recommend that you kind of spend a little more time just looking at and being familiar with. Triceps surae is one very specifically that is distinguishing the gastrocnemius and the soleus right here. And this video does a great job of talking about it. But that is known as the triceps surae. I don't know why they refer to it in that way. This video shows you what plantar flexion should be done. And if they have weak plantar flexors, they will have a triceps surae gait. So, this one I'll leave open to you. Where in the gait cycle is that going to be exhibited the most? In heel off and toe off, right? So, they're going to have kind of a really unique time if they have dorsiflexors. Now this is the question, if they don't have dorsiflexors, they're going to be dragging their leg, right? So what happens here is they don't get that foot up. So most of the time, what are they doing? They're probably sliding it. Now, in that instance, what we know, again, is traditional gait terminology no longer works. This is why RLA exists, because they don't have an initial contact. They could have a loading response, but they don't have heel strike.
Do these people just keep their foot dorsiflexed the entire time and pretty much just like walk?
Well, give me just a minute and I'm going to give you a little bit better look on that. Give me just a minute. Alright, so from our PowerPoint, we move into something known as muscle tightness and joint restriction. This one right here has some commonalities in the next section that we want to see. But number one, they have hip flexor contractures. What happens when this hip flexor is tight? And this is something we see a lot. If it's tight, it's going to pull the hips into flexion. Hip flexion contracture. Pull the hips into flexion. By doing that, that limits their step length. Because this over here is tight, meaning it won't let that step length occur. It also pulls their trunk forward, which also pulls their center of mass forward, which makes them a balance risk, or a fall risk, I should say. It also reduces the knee extension. So you have to look at this from a whole component. And the easiest way to do that is to come back to here and say, all right, if this thing's tight, right, what won't happen? Well, that won't happen. That won't happen. That won't happen. Because it will happen, it's just going to be happening in a reduced amount of distance. Or excursion, I could use that word. There's also something called a fused hip, where they may have a arthrodesis, a complete fusion, or they may have a bony abnormality where they just don't have the joint space to move in. They could have a knee flexor contracture, which would also contribute to a hip flexor contracture. Some people have knee fusions or ankle fusions that limit that motion. And when they do, their leg length is different. So let's take a look at what happens when the leg length is different. Number one, we will see a person who has a leg length difference when they have an amputation. Is that a Trendelenburg gait? Nope, that's a prosthesis that sucks when they got it fitted. It wasn't the right length. And so they're literally pistoning in the socket of the prosthesis. Now, you're not ready to talk about that yet. That's called a drop-off gait. You see it? And if you understand what a piston does, is it's an engineering term, but it would be going into a socket and back out. And so the stump will move into the socket too deeply. It did not fit correctly. Now, there's also where the prosthesis is too long. And what they have to do is they have to lift their leg abnormally high, which is a lot like a steppage gait, isn't it? But this one is not a steppage gait because they don't have weak concentric or weak eccentrics. I'm smiling. I wish you could see.
Eccentric, concentric.
Hikari's all over the map. He's like, I'll just throw them both out there and they'll get it right. Steppage gait is concentric. Foot slap is eccentric. Did you see how our guy here was moving? He's having to really elevate his knee through hip flexion. Why? Because his prosthesis is too long. Now, sometimes that's what they do if it's a transtibial, but when it's a transfemoral, there's a whole different set of circumstances. So let's show you that one. And again, I know you're not ready for that yet. but you need to see one called vaulting, and I thought that was in there. They will vault when it's a transfemoral prosthesis that's too long, because they have to clear room for that long prosthesis. And guess what? You're the PTA, you have to be able to pick up on these things. And you're like, wait, I'm not orthotics and prosthesis trained yet. What you're looking at is if the prosthesis is too short, they'll drop off into it. Or if it's malfitted at the socket. If it's too long, they just step through. Also, if it's too long and it's transtibial, they vault. This is called vaulting. And they hip height and plantar flex excessively to clear for the swing phase. They also may do this, and you've seen this one before, but I'm saving it for you to tell me where. In fact, you just look at this patient and tell me what you see. This is known as circumduction. Oh, we've heard that term before, haven't we? That's when, you go ahead. What kind of walkers you got?
Hemi walker.
Hemi walker, thank you. What's his problem? Oh, come on.
He's turning to lift that leg up.
Yep. In Gait conversation, yes. What's his medical problem?
He can't bend one.
I want something deeper. There's only one population using a Hemi walker. Yep. What side?
Right. Left, it's right damage, left paralysis.
I get confused when you said that.
I'm gonna hit play here. He's got his Hemi walker on the right side.
His right side and right on the left.
He's a right CVA, left Hemi. What hemisphere of the brain? This is gonna get some of you guys, and you're gonna be so mad, you're gonna come in here and pick up my computer and throw it. Please don't throw mine, throw yours. You're gonna say, but it said Hemi. And then your peer is gonna say, no, it said hemisphere. And you'll be like, of course. You gotta read the words. This guy has a right Hemi, a right CVA, left Hemi. See, it even gets me. He's using a Hemi walker. And notice what he's doing with his spastic Hemi side. This is in a extension synergy. Have you heard that before? They have to circumduct. Why? Because they have an extension synergy, which means the quads and the plantar flexors are hyperactive. We'll go with that. They're getting constant stimulus to contract. That's called spasticity, right? And they have to circumduct. Now, one more little thing here. Hemi walker, is it on the good side or the bad side? Yeah. And they lean into the good side. Why? Because it's all they've got. They can't use it on their Hemi side. Because do you notice what's happening up here? Extension synergy, flexion synergy. Man, I told you I was doing neuro tomorrow, right? I'm proud. I've been dusting all my neuro notes, boy. I'm ready to go.
Yeah, but are you saying flexion in the arm? Is that what you're saying? Flexion synergy in the arm?
Oh. Watch that leg. Circumduct. And if you think back to Heather, last year, you saw her circled up. You also knew, man, I love this talk because it just brings in so many good things. You also knew about Heather wearing a very specific brace called a AFO, ankle foot orthoses. And that helped to neutralize that plantar flexion for her spasticity from a extension synergy so that she would have a neutral ankle. That helped. But she still circumduct. She would still circumduct. And that brings me into this last thing, which is the hemiplegic gait. These are neuro things. They share a lot amongst each other. And then what we'll do is, today we'll talk more later. I'll go ahead and cut you out for lunch. The ataxic, the Parkinsonian, the scissor, and the crouching gait. Can we do 1 or 115?